thanks to the panel. I think that was very good and very provocative, which I'm hoping we can continue on with that. Because I had one. It was funny. I wrote these questions down and then heard what the three of you said and said, well, it's like they were reading my mind, because I thought, you know, we all know in the health sector, IT is not really taken off. But if you look every place else, if you look at consumer service and industrial world, it's exploded. A mom and pop shop somewhere in the middle of nowhere is more IT savvy than oftentimes an urban physician practice will be. And so why? The government didn't incentivize them to do anything. They just had to do this if they wanted to do business. So we're thinking kind of backward, to Meryl's point. I know a lot about the provider world or about the insurer world. Maybe this is probably crazy, and doctors will stone me if there's any. And Harry, maybe you will. But what if you let a doctor or an insurer say, you adopt IT, and I'll pay you in 24 hours, and I'll pay you a little extra. Otherwise, if it's paper or some other system, it's 3 weeks. I think people, because again, what happened in the private sector in these other places? It was business. It was their ability to do the work that they do that got us to ID. So I kind of throw that out there with this idea that, to Meryl's point, is that maybe not that specific example, but like that kind of thinking. That's how is that how we need to do this?
Yeah, well, that experiment has been done in the UK.
Okay.
So the ambulatory physicians in the UK were told if you use IT, that's how you get paid. And guess what? They have about 99% adoption in the UK among ambulatory physicians. Of course, in the hospitals, they don't have it because there is no similar incentive. There are all these areas where healthcare is slow to adopt very new technologies unless there's a compelling reason. And all of us can understand it. If you go into an emergency room having a heart attack and say, do you want to have the procedure that we've done for the last 10 years that we have excellent, well-known results on, or do you want to try this brand new thing that we're just trying out today? I mean, you're much more likely to say, you know what, I'm going to be conservative with my own health. So before we start getting overboard on hey, why don't we do this, this, and this, just think about how you make your own decisions about your own care for a second. So health is a little bit different that way. But there really have not been a lot of compelling reasons for people to, either for physicians to adopt health IT, or for patients to get engaged with it. How many of you have a personal health record? Okay, I'm going to guess that all of you have a personal health record, because I'm guessing most of the people have commercial insurance here. And therefore, all of you have a personal health record that's been provided to you by your insurance company. And yet none of you use it, or very few of you actually use it, because there's no reason to. There's no incentive. There's no saying that if you get information back and forth, your doctor will lower your payments. And frankly, there's no ability, frankly, to get that information to your doctor from your own personal health record. So we have a century of misaligned incentives for sharing information among providers, from patients to provider, and so those things are not going to change overnight. That's the beginning of it.
Just a quick comment on the incentive aspect. My own sense is that with the vast majority of people, if you get the incentives right, the vast majority of people do what they need to be doing, and they should be doing, and you don't have to worry about it too much. The problem is getting the incentives right. Typically, my experience has been the government often doesn't get the incentives right. It gets the incentives wrong, and it creates inefficiencies that it ends up instituting for years to come, and you can't get them out. So the current system as it's set right now, I think has got a lot of the incentives right. There is some money out there being pushed out for IT and medical records, electronic medical records, and so forth. I don't know whether or not those are going to actually come about, or if they'll come about in the right way. But if you get the incentives right, by and large, you can step back and let the system work.
So another question I had, which is I think a little bit similar to this, which is that we hear this word interoperability all the time, and again, it seems to be one of these, as Meryl said, coming down from the top. I asked this, fundamental question: Do we need interoperability? And I ask it in the sense that, look at the internet. Is it interoperable? I mean, to some degree it is, but how did that interoperability, again, blossom? Where did it come from? No one said this is it. It So the question really is, do we need to think about interoperability differently than the current paradigm we're thinking about it, and maybe look at it the way it's looked at via the way the internet works?
I disagree with that. And this is, my regulatory background coming out. This is human health, not email. I can get an email that I can't read and I'll be pissed off because the sender used some different software program and I'll be annoyed. But my health isn't compromised because of it. There's an awful lot hanging in the balance of interoperability in healthcare. And you've got groups like Continuum Health Alliance that are working seriously to try and develop some standards, not so much create standards on a whole cloth, but at least recognize standards that can be deployed to make sure that the various medical technologies can talk to each other. Because when they screw up, when they fail to talk to each other, people get hurt. You can't leave it as the Wild West internet. I'm as much free market as anybody, but that's not a good idea.
I think one thing that the focus on interoperability is often too narrow. The problem we have is, there are technological problems, yes, there are interoperability problems. The bigger issue is we have definitional problems to begin with. So, semantic issues of, what is obese, what is hypertension, what is diabetes, and what are these different measures that we're trying to move around, trying to get information back and forth, such that we have some way of comparing structured data and making good public health research. As an example, if we were able to look out and say, if the FDA discovers that there's an unacceptably high rate of adverse events with a particular drug, how do you reach out and identify, well, who are all the people between this age group and this age group who are at risk, who have this coexisting disease, who are on this drug, and have filled a prescription so we know they're actually taking it? How do we identify those sorts of things? So, in some sense, interoperability makes that easier, but in other regards, there's sort of much bigger fish to fry. And I think if we focus too much on sort of the underlying technical architecture, we're going to miss the bigger picture.
Well, just to be the contrarian, I'll go with Bill on this case. A congressman asked me about 4 years ago to go to a meeting where he had invited in some insurance companies and hospitals and others and doctors to talk about how you do interoperability in medical records and so forth. And the conclusion after 4 hours was, if the congressman would just give them all a couple of $1 million each, they would take it and they would go work on the issue. And I have never figured out why you necessarily have to have interoperability between, say, one hospital and another hospital with my medical record. I don't know why my medical record doesn't belong to me and I take it with me where I go. As far as I know, I've got a MasterCard. I don't have a American Express, but as far as I know, they don't have to be interoperable if I do have an American Express, so that they can talk to each other. It's my financial record, and I've wondered why, and I think Google and Microsoft coming up with their personal health record, I'm hoping that will be some kind of platform that eventually I, as the individual, am going to be able to take that with me. It was when Jeb Bush was still governor of Florida, but his health person called and said, the governor's got a good idea. He wants to take everybody's medical information and put it in a state database. And then everybody can reach out to it. And I said, I can't think of anything that would come closer to having the ACLU and the American Conservative Union absolutely opposing you by putting all that information in some kind of government database. Why don't you let individuals have their medical record, and they carry it where they want to when they go someplace?
So following up on this, and I might actually be in a place that's between there and here on the issue of interoperability. So, Aaron, to your point about, we shouldn't get too technical about it, yet we clearly might need some standards, so at least the right amount of the right data is essentially available and out there for what is a medical record. But then, Beryl, the question becomes to the bigger point of, yes, it's your personal health record, but we can all see why there might be a need for something broad, the information be used more broadly. For instance, if you are, again, to the point, following drug post-approval, if you're the CDC, how do we do that? So you're the CDC, you're trying to follow perhaps disease outbreak. You can see, I can see anyway, some areas where having greater access than just you having it somehow.
And I don't,
how do you deal with that?
I don't disagree with that. You know,
Okay.
for 10 years I was the ethicist on at UT Southwestern Medical Center on their IRB on human experimentation, where you want to try to follow those kinds of things. But as a patient who's not necessarily in the clinical trial, that's not necessarily my interest. My interest is I've got my medical record. I want to be able to go here. I want to be able to see this doctor, and I want that new doctor I go to be able to have access to know what drugs I'm using and my medical record, my medical history, and so forth. But what you're talking about is a sort of a broader interoperable system in which you can do mega data analysis and that type of thing. And I think that's fine. But that's a different deal than my personal medical record that I need for quality care. And so, I would make that kind of distinction. I have no problem with them trying to figure out how to do that.
And I think we're getting into a definitional issue as well, because medical records are, you know, very complex piece of information. So there's information about me, right? I'm allergic to penicillin. I've had certain things done to me, etc. However, there's also from the provider side of what did they do to you? What did they use? What kind of equipment was in their room? All these kind of things that really aren't necessarily relevant to your medical record, but are very relevant to the delivery of care. And so I may be interested in, you know, what medications you're taking when you show up in an emergency room when I see you, versus if I'm trying to do quality comparisons and value comparisons of providers and hospitals, I need information on how they have done on a broad population, and to sort of marry those two types of information together gets very, very complicated, and is one of the reasons where we are right now. I mean, for any of you who are going shopping online, right, you can get very good information on cost, on quality, on reputation, on other people's responses. You know, I go back to the open table example where you can identify a place which has the ambiance, the price point, the location that you want. And we're moving in that direction where people need to get this publicly available data and make choices based on those sorts of things, as opposed to sort of the blind leading the blind as it's been for so long.
Which brings me what I think I was trying to go to, which is this notion that when we hear health IT, oftentimes we're thinking about electronic medical records. I think a lot of people think that way, whereas in fact I think what we just demonstrated is it's an extremely broad area. And when you think that way, particularly from the regulatory, which brings me, Brad, just a couple of questions before we open it up to the crowd about the FDA. We talked a little bit beforehand. So two questions. Is the FDA prepared to, and are they preparing to regulate this new world? And how prepared do you think the industry is to engage with a regulatory body that many of them have never engaged with before?
Well, on the FDA side, the Center for Devices is a very large, sophisticated group of folks who regulate everything from pacemakers to all the GE scanners, and they deal with this kind of technology all the time, and they're staying fairly closely informed to the developments in this area, as close as they can. From a volume standpoint, obviously if they expanded their regulatory reach to start to have to approve and so forth some of these things, they would need more people, and there are user fees associated with most submissions, so they would get more fees and be able to hire more people, presumably. On the industry side, those are the folks that I represent, but I have to say, if I were mischievous, I'm not. But I could go to Silicon Valley and walk up behind somebody and say, FDA! And I'd scare the crap out of them. There's such a knee-jerk reaction after having seen so much in the media and so forth about FDA and what they do and how big and powerful they are and how complex it all is and so forth, that a lot of people in the IT industry want nothing to do with it. And I find it kind of strange, to be honest, because these guys will fight tooth and nail over selling a router with like a 0.5% profit margin. And the profit margins for medical technology are substantially higher than that, in part because you have to put a greater investment up front to make sure that the darn thing doesn't break very often. So I've been on the speaking tour to some extent saying, look, guys, medical technology and FDA isn't all that bad. It actually enhances profit margins because it eliminates the fly-by-night competitors, the guy who come in and try and, you know, come in with the cheapest piece of crap and works half the time, and you have to fight those people in the marketplace. FDA keeps that kind of stuff out, and that creates, frankly, in some ways, a better marketplace. So the answer is no, they're not ready for it, but they ought to consider getting ready for it.
I think it's also part of it's sort of the brave new world of healthcare, where lots of players that in the past weren't dealing with the FDA are now going to be dealing with FDA. But there are other agencies, most of 3-letter agencies actually now, where people are getting worried about. So there's FDA, there's FCC, who's getting involved in healthcare. IRS obviously is a big part of healthcare reform and their role in making sure everyone's covered. Department of Justice. I mean, the great irony in the Department of Justice, you have HHS that's trying to make everything paperless, and you got Department of Justice wants a paper trail. And you know, so there's some fundamental disagreements in government about how these things should be handled. But you know, a lot of these, I agree that you know a lot of organizations or companies that are getting into healthcare are now realizing that there's a reason that we have a lot of regulation, because it's a pretty dangerous industry.
Time for a couple of questions. Anybody want to ask any questions? Couldn't it possibly answer? It's got to be.
Sure. This might sound like a pitch for the Mobile Health Regulatory Coalition, but we're not, with Samsung, we're not actually members of it. But it just strikes me that the difference between a Chipotle app for your smartphone and a healthcare app for your smartphone is the Chipotle app is not going to get you hauled in front of the FDA. That fear does create a little reticence. I'm also curious from the, you know, so there's a fear of regulation, but I'm also curious whether there's also a fear of class action liability associated, and perversely would, you know, a little more FDA regulation help us there?
Yeah, there is a fear of liability. A lot of companies, for rational reasons, believe that folks involved in the healthcare system get sued more often than folks outside the healthcare system. And I've never done the statistical analysis of that, it's hard to say. But I'm sure it's true. And it's been a problem for the health industry before. Back 10 years or so ago, we found that a lot of folks were not willing to supply the medical device industry with silicon and all sorts of raw materials that were necessary to make medical products, because they thought they'd be sued too. And they came to Congress and got a special limitation on their exposure to liability. I'm not advocating the same thing here, but I am saying there is a lot of fear about getting into healthcare because of litigation, and whatever could be done to address that would probably be sensible.
I think you also shouldn't overlook that we are sort of a pretty traditional view of healthcare right now, and there's a large movement afoot that basically says that social media and patient experience, other things are the best and the fastest way of getting the most up-to-date information on the right way to treat cancer, the right way to find a physician, or the right way to treat whatever disease you might have. And that's a large and growing movement that believes that the health industry has failed most patients, and that there's a better way out there. I mean, the same people who recommend a better movie for you on Netflix are going to be the same people to tell you, what you ought to do about your prostate cancer.
And just to add to that a minute, I certainly am not opposed to the FDA. I think the FDA plays a critical role out there, and certainly with medical devices that are going to have a stronger health input. Having said that, I don't think anyone has ever accused the FDA of being a fast-moving organization. And some of the new technology coming out, you're on 3 or 4.0 before the FDA could even realize you exist and begin to work on trying to figure out whether or not this is going to be applicable. So I do think we're going to have a challenge of how you move a very fast-moving technology industry in a very slow-moving regulatory environment.
One more, if there is, just make sure. Otherwise, thank the panel.
So thank everyone for coming today. As my child would ask, are you going to talk about doctors and electronicals again? And I said, yes, that's what we're doing today. So thank you for coming here about doctors and electronicals, and understand that this is a kickoff for TechAmerica. The committee that helped organize this event has been around for about 2.5, 3 years. We envision the same kind of event next year, so stay tuned. And I imagine we will add some bells and whistles to that event as we go forward. I want to specifically thank all the people who helped organize and who spoke today. Content is the only thing that drives these events, and without y'all and the folks who spoke earlier, it simply couldn't have happened. So thank you for your time and your effort to come here today and share your thoughts with the crowd. Thank you again.